Airway maintenance. Secure the airway. The tube holder is best or use cloth tape. Confirm tube placement with an X-ray, CO2 detector and the CM placement. Patient communication such as speaking valves if able or a dry erase board. And adequate humidification such as with a HME, a heated humidifier or a LVN. Airway maintenance continued. Decrease infections with hand hygiene and HOB up 30 degrees. This is with all ventilation patients. Secretion clearance is done with suction. And cuff care, which is to measure the pressure. Troubleshooting airway emergencies. Tube obstructions, which are the main cause, can be caused by a kink or bite, in which case you should move the head or neck or reposition the tube. Herniation of the cuff over the tip, in which case you should deflate the cuff, or if that doesn't work, try to pass the suction catheter through the tube. Obstruction of the tube orifice against the tracheal wall. And mucus plugging, in which case you should use a suction tube if saline is not necessary. Troubleshooting airway emergencies continued. Cuff leaks occur. Mainly in mechanical ventilation. In which case a gurgling sound can be heard. Accidental extubation, which is less common with nasal intubation. Partial displacement is detected by decreased breath sounds, airflow through the tube and ability to pass the catheter past the end of the tube. With PPV, airflow through the mouth, nose or in the stomach may be heard. In which case remove the tube and manually resuscitate until reintubated. Measuring cuff pressure. Both minimal techniques are not preferred. Minimal occlusive volume technique is air added to the cuff to stop the leak on inspiration. Minimal leak technique is putting just enough air for a small leak on inspiration. Manual is done by pressing on the balloon to estimate. And Posey cuff flater is a device that measures and fills. 2 airway traumas. Their primary cause being tube movement. Other factors are duration and the pressure of tube. Laryngeal lesions occur only with oral or nasal endotracheal tubes. Most common traumas are glottic edema, vocal cord inflammation, laryngeal and vocal cord ulcerations and vocal cord polyps or granulomas. Less common but more serious are vocal cord paralysis and laryngeal stenosis. Tracheal lesions occur with any tracheal airway. Common traumas are granulomas, tracheomalacia and tracheal stenosis. Less common but more serious are tracheoesophageal fistula and tracheoinnominate fistula. Trauma preventions include sedation, which helps avoid self-extubation, swivel adapters which reduce traction, using the correct size, maintaining pressure which should be 20 to 30 cm H2O or 20 to 25 mm of mercury, and using nasotracheal tubes because they are easier to stabilize. Suctioning is mainly used to remove secretions. This is done with sterile suctioning, oral suctioning, closed or inline suctioning and nasotracheal suctioning. It can also be used to maintain a patent airway and collect a sputum sample. Suctioning continued. It is always PRN and should be done no longer than in 15-second intervals. Always hyperoxygenate with 100% O2 before because hypoxia is the #1 issue. Too frequent could cause atelectasis and hyperinflation is optional to reduce this risk. If no nasal trumpet is inserted, use loop. Suctioning size and pressures. Pressure should be set at -100 to -200 mm of mercury for adults. The size equals the tube's inner diameter multiplied by 2, then choose the next size down. Also the KU tip is used for left stem suctioning. Removing tubes. Indication for this is if the problem is gone. Extubation, which is done with endotracheal tubes. Starts by assembling equipment. Then hyperoxygenate and suction. Then deflate the cuff. Then cough, then remove the tube. Apply oxygen as ordered. And assess the patient and airway. Decannulation, which is done with a tracheostomy tube, is one step, just take it out. However, long-term mechanical ventilation patients need to be weaned, in which case start by changing to fenestrated tubes, then smaller tubes, then the button and assess the patient after it's out. RESP